Hello, this is Dr. Jeffrey Miller from Baltimore, Maryland. Today I'd like to talk about the Anterior Guided Growth Appliance. This is an appliance that is generally not used by orthodontic specialists. I'm sure there are some exceptions. Over the last several weeks, I've consulted with several patients that have used this appliance, and I can tell you that in each case there was significant damage done to these patients' mouths. And in this short presentation, I'd like to discuss what happened. One of the cases in particular was very well documented using cone beam CT. Was cone beam CT taken pre-treatment after the appliance was removed and 10 months into what they call the control arch, which is really just braces. I hope you find it interesting. My name is Jeffrey Miller. I graduated from Towson University, received my dental education from University of Maryland, my certificate in orthodontics from SUNY Buffalo, my board certification in 1991. I've been in private practice in Maryland for over 35 years. And I speak both nationally and internationally on cone beam CT topics related to the diagnosis and treatment planning of our orthodontic patients. I'm also a member of these organizations. I searched the web for general claims associated with the Anterior Growth Guidance Appliance or the AGGA appliance or the AGG appliance, whatever you want to call it. And this one particular website I thought had a pretty good general description of what claims are made for using this appliance. Growth guidance therapy for adults involves gently and safely stimulating the lifelong remodeling potential within the jaws and face. By correctly applying growth appliance strategy, the results are profound. These include creating room for crowded teeth, development of the face in a forward horizontal direction, which improves the appearance of the cheekbones, eyes, nose, and lower jawline. This opens the airway, potentially eliminating sleep breathing problems, and also gently improves the stability of the upper cervical complex C1 and C2, which are vital to total spine alignment. Now, I don't have any idea where they got these from. I've never seen a single piece of documented refereed literature that supports any of these claims, but that's what the general claims are. This patient, I assume her name's Amanda because that's what how they have her listed on this website. This was from a general dentist, and on her website it says facial growth orthodontics patient Amanda before and after AGGA mid-face expansion. Amanda has fuller lips, a more defined jawline, and cheekbones in addition to other positive changes. Now this patient Amanda, you'll see her photos before and after on several of the doctors that provide AGG appliance treatment. So I assume this is, I guess you could call her the poster girl for the AGG appliance. Now notice that the lighting's a little different, the makeup's a little different, but let's look at another claim. This is a YouTube from another dentist that uses this appliance, and he's claiming that Amanda has a 37% increase in forward growth. So what they make a claim that they get growth of this mid-face. So if you look at her lips, they look more full in this photograph compared to this photograph. Okay, so here's Zach, facial growth orthodontics patient Zach before and after AGGA mid-face expansion, showing a 250% increase in forward growth. Zach has fuller lips, a more defined jawline, and cheekbones in addition to other positive changes. So when you compare Zach and Amanda, you see they're projecting a line down from the corner of the eye, and they're measuring that distance to the lip. When we do this on Zach, you see he got about a 250% increase. The problem is Zach never had any AGG appliances. Took about 10 seconds, and the treatment method to get the 250% increase was all he had to do was turn his head slightly to the right. So when you look at most of these claims that are made, they're really a little bit weak at best when they talk about changes to the mid-face. Now, I did find one patient that actually did have changes to his mid-face. I don't believe they're positive, but now they are bowed. It looks like he's strained to get his lips together. Here his lips are nice and relaxed. If you look at the E line, you can see the changes, how these became much more procumbent. And when you look at this particular gentleman's treatment, he had orthodontic treatment at some point previous to the AGG appliance therapy, and you could see that he had 2 upper bicuspids taken out, and they opened up the space. Okay, so here on the one side it's 9.8, and on the other side it's 8.2. So they opened up the space. The idea is to advance this upper anterior segment so that the patient has more room for the tongue to fit, and supposedly the patient's going to breathe better, among the other changes that you heard in the description of the appliance earlier. If you look from the side view, you see that there's quite a bit of distalization of the molars. So if you have this molar is in a class, mostly class 1, and you could see after the appliance, the molars in more of a class 3 position. There are bite bumps attached to these molars which counter-rotate the mandible. But really look at the anterior teeth and the cuspid in particular. Notice the blanching of the gingiva here, and notice the change in the contour of the gingiva. Here he had a well-contoured gingiva that looks healthy, and here not only is it blanching, but he's starting to get recession of the gingiva associated with this cuspid. Now, I can tell you that you generally do not see the gingival recession associated with orthodontically pushing a tooth through the bone support for that tooth until 5 to 15 years post-active orthodontic treatment. So when you start to see gingival recession occurring during active orthodontics, you know you have a problem. And there is really a problem here. And you know, the interesting thing to me, or the most fascinating, is that someone would look at this case and be proud of it, that they think this is good treatment, and they're proud of this 9.8 millimeters and the 8.2 millimeters. It just shows you how completely clueless they are. And if you take a look at the facial changes, I mean, this guy was a nice-looking guy with a good smile, and now he's got these buck teeth on the front that are protruded out. Now, there was no profile picture. He has the front and the 3/4. My guess is the profile picture showed that the upper incisors are so flared out that it looked ridiculous. Here is a cephalometric x-ray of changes. I don't know 100% that this is the same patient. I would assume it is, but you can see they opened the space for the implants. They advanced the upper incisors. And you can see here that originally the tooth was well centered within the alveolar bone, and then after treatment the tooth was pushed, what appears to be pushed out of the alveolar bone. Now also I think we're tracing a cuspid here and an incisor here. It's not really clear what's going on other than the tooth was advanced slightly forward. And of course there were bite bumps there. You can also look and see how these molars were distalized. So most of the change that occurred was the distalization of the molars, not the anterior movement of the upper maxillary segment. So what would this look like using a cone beam CT to evaluate the changes? Well, I consulted with this one gentleman, and the doctor that was treating him had cone beam CT capabilities and took a cone beam CT pre-treatment immediately after removal of the AGG appliance, and then another cone beam CT was taken 10 months into treatment. At that point, the patient realized there were problems with his mouth, and he went and consulted with a couple orthodontists, his patients in California. He somehow got a hold of me and sent me his diagnostic records to evaluate. If you look at the pre-treatment photograph, this patient had 4 first bicuspids taken out during his first orthodontic treatment. He looked like he got an excellent result considering this is over 10 years post-active orthodontic treatment. It's held up beautifully. There's nothing I would change here. It's an excellent result. Although the dentist that was recommending the AGGA therapy said there's 56 millimeters of width on the upper that needs to be 60, and the lower arch is 52 and it should be 56. I have no idea where they get these numbers. I've heard this before. I can tell you that you can arbitrarily expand those arches, 4 millimeters, but they're not going to stay there. Over a period of time, they'll relapse back to at least a 56 and maybe even a little smaller. He did seek this treatment because he had sleep apnea. I asked him specifically if this appliance therapy helped his sleep apnea, and he said he wasn't sure. He said that he not only did he do this AGG appliance therapy, but he also did some other things at the same time. His sleep apnea did get a little better, but he didn't know whether he could contribute the improvement to the appliance or not. Here he is 10 months into the control arch, or 10 months after the appliance was removed. They put the braces on. They call it the control arch. You can see the bite bumps here in the back. You can also see how the molars got expanded. There was no appliance on the lower second molar, so they probably stay where they are. You can see the step out here. But look at this. There's not that much change to the anterior segment that you can see. Keep in mind the bite bumps cause counter-rotation of the mandible backwards, which is responsible for more of the overjet increase than anything else. If you were to look at this from a cephalometric perspective, here these are recreated cephalometric x-rays from the cone beam CT. I can see where you could get an impression that there was forward growth of the maxilla forward. And you can see here that this tooth, if you compare the initial with the appliance removal cone beam CT recreated ceph, the upper incisors appear to be pushed forward, and that's probably where they get these claims from a two-dimensional cephalometric X-ray. You can see from the Panorex, you see the bite bumps that they put in to disclude the teeth. If you look at the three cuspids, upper cuspid changes in width, you can't do this with a cephalometric X-ray or pan. You can do it with a cone beam CT. The changes in the width at both the apex and the clinical crown really are pretty much insignificant. So there was really no width change in the cuspid region. And if you look at the upper incisor, this is pre-treatment. If we slice through the center of the root, you notice that there's already some root blunting or root resorption that had occurred, probably related to his first orthodontic treatment, where the root's a little shorter. It's probably not clinically a problem at this point, but notice that the tooth is fairly well centered within the bone housing. Okay, the root is here. You see there's cortical. You can see cortical plate on both sides from both the sagittal and an axial view. If you look at the same slice at the point where the appliance was removed, first thing that you should notice is that there was significant root resorption associated with the forward positioning of the upper incisors. So if the bone moved forward, it would be unlikely that there would be root resorption. In other words, the bone was pushed through the limit of the bone housing, and that can be associated with root resorption. And if you look at the individual slices, you can see here that now appears that the root is dehisced from the facial, from both the axial and the sagittal view. The coronal view just really looks at the interseptal height. It's difficult to diagnose dehiscence and fenestrations using a cone beam CT when the teeth are being orthodontically maneuvered. You really have to let the tooth reach its final destination, wait about 6 months, and then take a cone beam CT, and then it's probably more appropriate to make a judgment about dehiscence and fenestration. However, you can get general ideas of what happened in terms of movement. Remember, the claim here is that they're moving the mid-face or the upper teeth in a horizontal forward position to allow for more room for the tongue. So this is the claim. And then if you look at the patient 10 months into the braces, or what they call the control arch, You can see here the root resorption has gotten worse. Now there's the clinical crown ends here. The root's approximately from here to here. There's hardly any root left. If you take a slice and you look at the image, you can see now that there appears to be significant dehiscence associated with the lingual aspect of that root. So what happened if the teeth were pushed forward and then retracted? So if we look at the three images, what I believe happened here was that the teeth were advanced past the limit of the facial cortical plate, and then they were retracted. So during the time these were advanced, you have an adaptive resorption process that causes this palatal bone to try to comport with the position of the root once the tooth is pushed forward. It's called adaptive resorption. And you can't look at it and measure it on a Ceph or a Panorex, but on a cone beam you can see it. So they moved this tooth forward, they lost bone on the lingual, and then they retracted the tooth back. And that's why you see this dehiscence. Now I believe when you see this magnitude of dehiscence from both the axial and the sagittal view, that there is something going on there. I mean, I don't know that definitively that's how much dehiscence, but that tooth is in a worse position now than it was when it started. But let's look at the actual changes to that tooth. Remember, the claim was we need to take this tooth, we need to advance the tooth by growing the bone. Remember that what the claim was, the potential growth of the bone forward to improve the profile and to allow more tongue space, or the volt, or oral volume, so that the patient can breathe better. So if we superimpose the pre-treatment with the a point where they remove the appliance, you can see that there was really no bone changes in terms of growth at all. The tooth movement was all dental. It came forward and went through the bone housing versus the bone housing moving with the tooth. And the best evidence of that is that the root got resorbed in a position directly related to the dehiscence. And if we compare the pre-treatment and the 10-month position of the tooth, that tooth, there is almost virtually no change, just minimal, and there's still spaces on the side to close. So now you have a potential for the post-treatment position of this tooth to be behind or be posterior to the original position of the incisor. So the idea was to advance this, but they actually may end up with loss of oral volume. And if you look at the pre-treatment photograph with the 10 months into treatment, see these spaces? They still have to close these spaces, which means that these teeth will probably have to come back a little bit just to get that space closed. And the overjet you see is really more of a result of the bite bumps than anything else. So if we look at the difference, the superimposition, you see this is probably 2-3 millimeters. That's hardly anything. So he went through all this treatment for really a change in the best case scenario of 2 millimeters to the anterior incisal edge of the upper maxillary incisors. Now the patient's going to need at least a couple implants to fill in those spaces at $3,500 to $4,500 a piece. With the damage to the bone here, they're probably going to need some kind of periodontal surgery. That could be anywhere, according to Google, between $500 and $10,000. I would guess when these kinds of surgeries usually run about $3,500. So when you look at this appliance and it says anterior guided growth appliance, first of all, there's no anterior component to that. Orthodontists use a similar appliance called a distal jet, but they're not trying to advance the anterior segment. The distal jet has a much more robust anchorage system in this acrylic pad. They're using it to distalize or drive these teeth back, which is primarily what happened here. And there's absolutely no growth associated with this. I mean, that is just a complete joke that they're calling it a growth appliance. It's really a distalization appliance. So in summary, this patient had significant bone loss associated with the upper incisors. They had additional root loss of the upper incisors. The roots got shorter. The bite is compromised compared to the pre-AGG appliance treatment. There's been negligible changes to the midface, negligible changes to the intraoral volume, which was part of the reason for the treatment in the first place, to open up the volume for more tongue space. He's now going to require at least 2 implants. There's a poor prognosis long term for the health of the upper incisors, which could lead to loss and therefore requiring bone grafting and possibly 2 more implants. Likely to have the need for periodontal bone grafting. Loss of time, effort, and money associated with the 2 years of this treatment that really did not meet any of the goals that originally were prescribed. He did have an increase of the upper molar width of 4 millimeters, but that's an unstable movement. And he had an increase of the lower first molar width of 6 millimeters, which are also unstable. There was no real change to the upper arch width at the cuspids. So the short-term actual costs, short-term estimated cost, is about $25,000. So this patient's going to need to spend about $25,000, and he's still going to have other consequences. His mouth is never going to be as good as it was when he walked in the door. Thanks for listening. If you have any questions, you can email me at drmiller@orthodonticassociates.com. Thank you very much.